We see that this health center, about 50% are uninsured, and 98% of all of our patients live under 2% of poverty. So it's a very needy population, but it's also a population trying really hard to stay well. I mean, you can afford least to be sick when you're poor.
If they do have insurance coverage, they're more working poor and have high copays. So access to care, access to medications and copays or cash out of pocket, it's difficult.
Indigency is an issue within that population. I think language and culture is a big issue. Variety care tends to have a largely Hispanic population. I'd say about 50% of our patients are Hispanic.
They're not just on one medication, and when they're on 4, 5, 10 medications, it adds up very quickly. So I have patients that, they'll choose, well, I can't afford, so I stopped taking this because I thought I needed this more.
It was more a problem with not being able to get the medication that was needed, or not being able to afford that month of medication, or with diabetes, even the food matters. So it's only being able to afford food that's cheap, which is carbohydrates and fats and processed foods, and so it isn't that good for diabetes.
With any indigent family situation, there may be one parent, there may be abuse within the home, money is an issue, it creates tensions, and there are some people who are so stressed and so anxious about just living that diabetes is not number one, and that stress is actually hurting them physically, and they know it.
Social problems, financial problems, work-related issues, having to travel outside of the metro area to even find work, be gone from the healthcare system for a while. So I would say that we just try to establish rapport early and identify what the issues are, whether it's lack of understanding of what the medications are for, whether it is truly resources, and what do we have that can meet their needs through patient assistance programs.
We've seen some patients that A1Cs were as high as 18, and with being able to apply pharmacy services and education and the follow-up, and one patient that had an A1C of 18 is now running in the mid-8s.
We've seen, light bulbs come on in our patient population where they now understand where they should be. They now understand how to better organize a meal, and they're implementing these. We start to see self-management techniques where they're making decisions and they're troubleshooting, as opposed to us having to educate every time.
The most notable patient experience that I've had thus far is I had a patient who didn't have health insurance, so really just hadn't followed up with a physician in several years, had fallen out of the system because he said, well, I don't really have the money to pay for it. I'll just live my life and just feel bad because that's just what diabetes means. That patient's A1C came back greater than 18 because that's as high as the lab could detect. We did start him on a basal insulin and an oral insulin sensitizing agent. No bolus insulin, only those two and lifestyle changes. And 4 months later, his A1C was less than 7.
Success for me is if each person enrolled understood about their diabetes a little bit better and was knowledgeable to the point that they would act on their own behalf.
I want to see patients that are more empowered to take active control of their disease. I want them to say, you know what, I have diabetes, but this is what I've done, and now I am controlled.
I think that with these tools, I think we'll have a lot more people who say, I think I can get well. I think I can participate in my own process. And I think that one-on-one clinical pharmacy piece, we've just seen that that's the key that unlocks a lot of help.